Good afternoon, everyone. So I'll be arguing against Y90 in colorectal cancer, mostly. So as Dr. Kennedy nicely described in the beginning of his talk, we have done pretty well with systemic chemotherapy for metastatic colon cancer, especially with incorporation of our biologic therapy, with survival ranging really from the high 20 to mid 30 months. But of course, as we all know, we can do better, we want to do better, and especially in our patients who present with oligometastatic disease or with limited disease, particularly to the liver, we really do try to incorporate regional therapy. The question is, though, which regional therapy is best, and is Y90 or SIRT really the right choice? So thankfully, Dr. Kennedy beautifully described Y90, so I don't have to go into that. And we also know that regional therapy with Y90 and hepatic intraarterial infusion is a part of the NCCN guidelines in the salvage setting. And these data really are based on what was just described with the benefit of the addition of Y90 to systemic 5-FU in the refractory setting. So I don't need to go into detail on this point, but there was some benefit with Y90 when added to 5-FU, and several other studies have also demonstrated a bit of a benefit in the salvage setting. But if we think about what other regional options are there, obviously being from Memorial, we utilize a lot of hepatic intraarterial therapy with the pump. And we wanted to actually take a look and see a little bit comparing apples to oranges, because these were two different institutions, but what does better in the salvage setting, Y90 or HAI therapy? So this was work with Dr. Carpizio actually at UMDNJ, where the predominant focus was Y90 in the salvage setting. So here the patients were heavily pretreated. We've tried very hard to standardize re-read scans, et cetera, to make sure that the disease burden was equivalent. And then we took a look at responses, either stable disease, or progression, et cetera, and overall response. And we really did see a significant benefit with HAI over Y90, as well as a significant survival benefit. Of course, again, different institutions, different patients. This was not a prospective study. This was just a retrospective look. And what we really concluded here was that perhaps if regional therapy should be utilized, we should attempt hepatic intraarterial infusion first, mostly in addition to these data, because once Y90 is performed, the liver pump can't be inserted, and that's something that, again, we deal with a lot at our institution. But I will say that as regional therapy is gaining favor, there have been many institutions coming through Memorial who are now starting pump therapy, so it may not remain so limited to the Upper East Side. So what about first-line therapy? And I know that Dr. Kennedy just mentioned that this was a negative study, but I thought it would be a good thing to spend a few minutes just looking at the data. So 3 combined studies, SURFLOX, Foxfire, and Foxfire Global, over 1,000 patients total, treated with first-line systemic chemotherapy, either randomized to either FOLFOX with bevacizumab, or FOLFOX and later on bevacizumab, and treatment with Y90. So the treatment schedule was standard FOLFOX chemotherapy in the control arm, and in the experimental arm, patients received Y90 with the first cycle, lower dose of oxaliplatin for the first 3 cycles, and then thereafter standard FOLFOX with Avastin for those that could receive it. And the primary endpoint was overall survival. Secondary endpoints were PFS, liver-specific PFS, hepatic response rate. So bottom line, this is a negative study. There was no benefit in overall progression-free survival or overall survival with the addition of Y90 in the first-line setting. Really superimposable graphs. Looking at treatment characteristics, there were less patients who were able to receive bevacizumab in the Y90 group, as well as less oxaliplatin. And importantly, I don't have it in this table, but less patients went on to receive second and third line chemotherapy in the patients who received Y90. Looking at toxicity, there was more toxicity, predominantly hematologic, not so much hepatic toxicity, which we might have expected, but nevertheless more toxicity in the Atrium 90 group. And as far as the best response, we always like to talk about liver progression-free survival or liver response rate, and kind of discuss, does this actually translate into a survival benefit? And clearly in this study it did not. And looking a little bit more at the response rate, did the response rate actually lead to an improvement in resection rate? Because obviously that is the ultimate goal, especially in the first-line setting. And unfortunately there was no benefit here either with the addition of Y90 in terms of getting the patients to resection. The authors did point out that looking at tumor location with the right side and left side story, is there a side that benefits most? Perhaps right-sided tumors with worse prognosis. There seemed to be a trend here that these patients did benefit, but I will caution that it's a really small number and that this was an unpreplanned analysis. So we really can't make too much of this outside of possibly a future clinical trial. So in summary, the benefit of response rate didn't translate into an increase in resection rate. Hepatic PFS did not translate into PFS or OS benefit. Fewer patients went on to receive second or third line chemotherapy, and there was an increased toxicity. And again, I just discussed the right-sided finding, which really we can't do much more than just say, okay, it's a hypothesis generating, perhaps we can look into that in clinical trials. So then looking at HAI therapy, this was a study conducted, led by Mike D'Angelica at Memorial. Patients had were either chemo naive or had first-line chemotherapy, and then went on to receive second-line chemotherapy. They did not all progress on first-line chemotherapy, but nevertheless, you could see a beautiful waterfall plot with the addition of HAI-FUDR to systemic chemotherapy. 52% of the patients were converted to resection, and the response rate was 83% in the chemo-naive patients and 73% in the patients who had HAI in the second line. And this did translate into a PFS as well as an OS benefit in this group. So I think in conclusion, oh, sorry, that is strange and out of order. So survival has improved with combination systemic chemotherapy. That we know. Patients do benefit from regional therapy. The data seem to support HAI over Y90, but we can argue that. The addition of Y90 to first line is a no-go. I think we both agree with that. Toxicity is a concern. I think toxicity is a concern in the salvage setting as well. And again, earlier lines of Y90, including second line, in my opinion, should be utilized in clinical trials only. Thank you.